Good morning.
Good
Just,
morning.
give it a few moments. We'll get going. I guess we're pretty good here. So why don't we start? Okay. Right. This is an ECG that I received via fax. And so this is real world because the tracing quality is lousy because we're looking at a faxed copy. I scanned it at the highest res I could. So question for you is, do you have any idea regarding the mechanism of this tachycardia? I should say we don't even have little boxes on this tracing, so you'll have to take my word that this is a heart rate of 190, why don't we say, for the sake of conversation. Um, and the tachycardia did terminate. So this is the rhythm. This is what the EKG looked like afterwards. And because I'm a nice person, I will show you both of them at the same time. So, um, anybody want to hazard some guesses regarding the mechanism of tachycardia?
I can take a guess. Good morning. Looks
Right.
like you said it's a heart rate of about 190 in a 17-year-old, so that's pretty fast for me. And
Mm-hmm.
then looking at the overall morphology and access looks similar. I don't see P waves. And I think what I'm trying to better delineate is whether or not there's a short RP or a long RP. And I think I'd venture to guess this is a short RP, if anything, because I don't see one clearly after the T wave. Makes me think this might be like a typical AVNRT or orthodromic reentry.
Well, maybe you can expound on what you mean for the junior fact fellows. What do you mean by a short RP or a long RP, Vlad? I agree with your general comments, although I'm not sure. Well, yes, I agree with your general comments, but maybe you can expound a little bit on what you mean by a short or a long RP. We're still in September of the first year fellowship for two outstanding junior fellows.
I'm looking for is the distance between the QRS complex and the tachycardia to the P wave that would be after it. In this scenario, I don't see a clear P wave, but sometimes you can have a P wave afterwards, and then you kind of look at that duration. I believe we used a cutoff of about 60 milliseconds. So if you've got a duration of greater than 60 milliseconds between the QRS complex and the following P wave, then that characterizes a long RP tachycardia. And then there's a different effect.
It's actually 70 milliseconds.
70. Thank
Yeah.
you.
No.
Um, but then if it's longer than 70, then it's a slightly different differential than a
Right.
short RP.
So I'll just draw here. So, if we imagine that you can see this little stupid drawing in the corner here.
Yep.
Yes. Okay. So generally speaking, if you're going in ORT and you're going down the node and then back up the pathway and then back down the node, um, this process should take a minimum of 70 milliseconds. Um, Let me see if I can erase this. Can I go? It's cool. Whereas if the reentry is all within the AV node, right? Then in theory, the retrograde A's, right? Remember that when you're in AVNRT, sorry, when you're in AVNRT, the reentry is occurring here, and the atrium and the ventricles are depolarizing passively from the reentry that's occurring just above the level of the His bundle in the AV node. And so what that means is that in theory, the atrium can depolarize exactly on time with the QRS, might even potentially depolarize before the onset of the QRS because it might take longer to go through the His-Purkinje system from AV node to ventricle than it takes to go from the AV node back up the atrium. And that's not uncommon that people with AVNRT, typical AVNRT, that the which would be long, short AVNRT, so fast pathway going retrograde, slow pathway going antegrade, that the atrium will actually depolarize before the onset of QRS. So the general rule of thumb is that if you're in ORT, the time between the QRS and the next P wave, as Vlad said, should be generally more than 70 milliseconds. Now, my good friend and former colleague Scott Seresnak wrote a paper in which he discovered that actually it might be as you might have ORT in small children with an RP interval as short as 50 milliseconds. So the 70 may be a little bit of an overstatement or an exaggeration, but I think it's probably it's certainly what most people consider to be the reality of this situation. So basically then, I think the next question is, can we tell on this tracing whether the R to P interval is longer or shorter than 70 milliseconds? And so this is why I'm showing you both the 12 lead in sinus rhythm and the 12 lead in tachycardia, because what you're trying to do then is compare what is going on from the moment the QRS depolarizes to the T wave in order to see if you can convince yourself that there may be an inflection, early or late following the onset of the QRS. It turns out that this patient actually, I believe, had AVNRT. But it's hard to say, right? Because, for example, if you look in lead 2, the T wave looks a fair bit different, right, than the T wave in sinus. So the question one might have is there a P wave that might be a retrograde P wave that might be inscribed on top of this T wave? However, I think you correctly and astutely pointed out, Vlad, that there does appear to be a little bit of an extra complex at the end of the QRS in lead 3 that we don't see in sinus rhythm. And it looks like it's right on top of the QRS. We actually did a study a number of years ago in which we took the EKG, 12 lead EKG of children who had had ablations for SVT and whom we knew definitively what the mechanism was. And what we did was we cut the 12 lead EKG into 12 pieces. And then me and Leo Lieberman sat down and spent hours and hours trying to determine if we could guess what the mechanism was. And we looked and tried to ask the question, which lead was the best to figure it out? Or in other words, which lead was the retrograde P wave most obvious? And it turned out that it was leads V1 and lead 3 that were the best. And lead 2 was lousy, which is interesting because we normally, in many ICUs, lead 2 is the lead that is displayed pretty traditionally. But actually, it was lead 3, and I actually think in this is a nice example where I think there is some evidence that the retrograde P waves can be seen a little bit better, but it's not a very obvious one. And many of you know that when I am when we're sitting in the control room prior to the case and we're trying to figure out what is the mechanism, I'm generally don't think that I know the answer to that question very well because it can be very challenging to see the retrograde P waves, not to mention the fact that this is obviously a very poor tracing because it's been copied and scanned and then scanned again. So now, tr officially, we would not call. So Vlad, you were explaining that if the QRS is more than 760 or 70 milliseconds, that would be more consistent with orthodromic reentry. If it's less than 60 milliseconds or 70 milliseconds, it's more consistent with AVNRT. We do know, of course, that atypical AVNRT, where the retrograde pathway is the slow pathway, they can have a long R to P interval as well, or a longer RP interval. So you do have to keep that in mind. And when people say a long RP tachycardia, um, what they usually are meaning is a very long one, such as is seen in PJRT, right? So we remember that in PJRT, there is an accessory pathway that conducts very slowly, much slower than a normal accessory pathway, so that the RP interval is, yes, it's greater than 70 milliseconds, but it's often greater than 170 milliseconds. So officially in the literature, when people refer to the word or use the terminology long RP interval, what they usually are connoting is something where the R to P interval is like more than 150 milliseconds. You're using that term long RP in comparison with a short RP, but I think I would probably just be more specific and say greater than or less than 70 milliseconds. Just nomenclature can sometimes be confusing in electrophysiology, and it is a lot of the field is just, properly naming things. Okay. Any questions on that?
I have a question, Dr. Pass. Suppose we get this as a tracing in our boards,
Mm-hmm.
and they ask us to identify if we can identify what is the mechanism of the tachycardia of the SVT. Just
Mm-hmm.
because this person is an adolescent, and because of the heart rate, can we say that this is without other evidence like like RP interval and all that, can we say like this is an AV and RT?
That's a good question. So, am I correct in assuming that you're trying to make the observation that adolescents are more likely to have AVNRT than ORT?
Yes.
And that the heart rate being about 190 is a little on the slow-ish side for SVT, which would be more consistent with AVNRT. Is that the reason you're suggesting that even without the RP, we might be able to infer that?
Yeah.
I think those are both very reasonable assumptions, but they are not rules of thumb. And so I would say, no, let me rephrase that. They are rules of thumb, but they are not definitive. I would say that if I don't believe a tracing of this type would be on the boards asking that question because I don't think it's clear enough. I think that they would probably give a 12 lead ECG tracing in which it was very obvious that there is a P wave, and that would probably be between the QRS and the T wave. The general rule of thumb, I would say, is if you can easily see retrograde P waves, it is likely that the R to P interval is greater than 70 milliseconds, and it is likely ORT. Now, you could have other arrhythmias with a long RP, like ectopic atrial tachycardia, or atrial flutter, where the atrium is, independent of the ventricle. But I think that, if you can't tell and you're guessing, certainly the heart rate being 190, the fact that it's an adolescent, you can certainly, I would say from uh, a population-based approach, averages, you have a good shot of getting that right. But I would probably assume that if they're showing the 12 lead, that they probably want you to interpret what's in the 12 lead as well. When I was taking many years ago, I was taking my board recertification exam, and they showed a case of like a 18-year-old Fontan patient who was tachycardic, and they showed the intracardiac tracing, and they wanted to know what was the arrhythmia. Now, I would make the argument that for a general pediatric cardiology board that is not an EP board, I would have used the way of analyzing it that you did, Katoki, which is, well, is there some way I can figure out what this is even without looking at the tracing? So if I said to you that I had a Fontan who had a heart rate of let's say 140 and was tachycardic, I think all of us would agree that, like, what would you say, Katoki, would be the most likely, just if you were going to guess, mechanism of tachycardia in a Fontan patient?
Like an IART?
Right. We would have thought it was exactly. We would have said, oh, it's probably IART. But it turned out that it was actually VT. They were actually in the intracardiac tracing, there were many, many more V's than A's. The tachycardia rate was, as I said, 140. The atrial rate was like 40 or 60. And it's kind of a funny story because at that time, they were considering to put me on the board to make questions for the board. And I foolishly on Facebook wrote that I just took the board exam and I was very unhappy with one of the questions because I felt it was unfair that it was essentially forcing non-electrophysiologists years after their boards to interpret an intracardiac tracing of VT in a Fontan. Whereas I would make the argument that just knowing that IART is very common in Fontan patients should have gotten you the answer to that question. Anyway, one of my colleagues was nice enough to share this displeasure of mine with one of the board members, and I was uninvited to be a question writer because they felt it was a perfectly reasonable question. It turns out the guy who wrote the question is a very dear friend of mine, and he was pissed off at me. But anyways, so yes, I think in general you should use the knowledge that you have. In other words, if I didn't have, like in the olden days before we had fax machines, sometimes the fellow would call you and just say, I got a 17-year-old who's in tachycardia and it broke with adenosine and the heart rate was 190, and that's all you would have at night in terms of understanding what was going on. So it is important to know the epidemiology of your patients to help inform your diagnoses or thoughts on this. So yeah, I agree with that. Right. Any other questions? All right, forward. Okay. This is an old school Holter on somebody who has a problem with their pacemaker. And maybe you can tell me what is wrong with this pacemaker. Does anybody want to take this one on? So we went from fast now to slow. Why don't we ask Dr. Kaloff if he has any thoughts on this?
Good morning, Dr. Bass.
Morning. By the way, you could feel free to tell me if I'm wrong that there's a pacer problem. Sometimes I will be tricky that way. I will tell you I'm not being wrong this time.
Yeah, I think you're kind enough that you're not trying to trick me.
Not in this one, no. So on the top tracing, how does this look? Would you agree that this looks like it's working okay?
It's very bradycardic. The rate is about
What is the rate?
60 or something.
Yeah, it's about 60, 65.
Yeah.
That's pretty consistent, right? It's pretty regular.
Yeah.
Two leads of the same patient simultaneous, by the way. This, by the way, just for the record, this is like an old school Holter. This demonstrates what was better about Holters than, say, Zeo patches. What was better was that you would routinely get two leads of the patient because there were typically 5 leads that were placed on the patient. You might say, well, why did we stop? And they do still exist, of course. You can order a Holter here, although Robin will give you a hard time. The reason we don't do Holters is because the independent EKG stickers would fall off very often. So it's very common that you put a Holter on somebody in the office, and when you got the monitor back, there would be 11 hours of recording, and then it was just basically gone. So the general approach is it's better to have 3 days of consistent tracings of one lead than to have 11 hours of 2 leads. So might not be true, but that's how we think about it. Okay, so So at 4:39 p.m., it appears as if everything is okay. What about at 6:20?
So I think it was a sensing problem. So the second and third beat, I think these are the native heartbeats for the patient.
Okay.
That was the pacemaker was not sensing, so and it wasn't or it didn't capture
So,
the heart
okay,
didn't
so
capture the
why don't we start at the first beat? So this beat, does everything look okay here?
I think it looks like somewhat similar to the previous.
Okay, so we
I
have a
mean,
pacing spike.
it looks distorted, so I don't know if it's
Yeah, it is a
yeah.
little distorted. That was another problem, by the way, with old-fashioned halters. They were actually on cassette tapes, and sometimes the machine would move a little faster or slower, and so the QRS would widen or narrow, and you had to sort of figure that out. But anyway, eventually they became digital. All right, so here we have a capture beat, and then here we see a pacing spike, and what happens here?
It wasn't captured.
It's not capturing. So we have an example. So how would you, what is this problem? What would we say is wrong here?
Um, that the threshold is low.
Actually, the
The
threshold is
out
high, right? Something's wrong with
right.
the ability of the pacemaker to consistently capture, right? Because a pacing spike this long after the prior QRS should have captured, right? So
Right.
there's some problem with ventricular capture. The fact that it captured here and doesn't capture here suggests maybe the pacemaker's threshold has risen. And, normally when we're programming a permanent pacemaker, Mohammed, how how high do we set the output relative to the threshold? If the threshold, for example, is 1 volt, how would you set the output on a permanent internal pacemaker that's been in for a long time?
I think we usually double it. At least
That's
we do
right.
5.
That's right. We would usually double it. So if the threshold is 1, we would pace at 2. But sometimes, and the reason that we double it, you might say, well, why not just pace like a tenth of a volt higher? It's because thresholds change based on physiological state, and leads change over time as well. And so the general thought is it's safest to have an output that's about double what the threshold is to ensure capture the vast majority of the time. But thresholds can suddenly change, and double output may not be adequate. And so it's one possibility is that, the threshold has risen, and so that maybe the output is programmed very close to the threshold so that sometimes it captures, sometimes it doesn't. We can't really tell. Then you're right. We have 2 beats that appear to be conducting, although the PR appears to be lengthening. So makes you wonder if this patient has like some kind of like high-grade second-degree heart block, because it feels like these 2 beats are conducting, although maybe the next beat would have wanky buck. What do you make about this? What do you think about this beat here? Does this suggest any problem? Does feel like there's a paced complex, right, with the QRS.
Yeah, it's very close to the previous beat. I think it's like the pacemaker has low sensitivity, so it's not sensing the
Right.
heartbeat
So
because
the proper way to say that is to say it's under sensing, right?
right.
Because it seems unlikely, like this rate is like faster than 150 beats per minute.
Yeah.
So, and we see here what the R to R, what the pace to pace interval is, right? So it's quite a bit slower than that. So clearly the pacemaker is not programmed to pace at this fast of a rate. Now you could argue maybe there's a rate responsive feature on the device where it's sensing activity and it's it's increasing the heart rate. But I think this is an example of undersensing. In fact, you can see this is potentially very dangerous, right? Here's the T wave, and here's the paced complex on the ventricle. If this pacing spike had been a little bit earlier, maybe 5 or 10 milliseconds, it's possible that this pacemaker might have induced VF from putting an R on T phenomenon. So undersensing is a very serious concern. You know, it's not uncommon, and each one of you is going to be in the situation when you're on consult where you're going to get a call that some patient of ours who has a pacemaker needs to go to the operating room, let's say for an appendectomy or, ENT surgery or something. And they'll ask the question, can we put a magnet on the device temporarily? Why did they want to put a magnet on the device? Does anybody know?
They use the diathermy might interfere with the
I can't hear you. I'm sorry,
like
Mike.
any. I mean, any patient movement, any like using diathermy can affect the how the device, like what the device is sensing, what the pacemaker is sensing. So it might be interpreted as a heartbeat, and uh, the the pacemaker wouldn't then pace the patient as it
Right.
should.
So electrocautery is unipolar usually, and it creates a very, very large electrical artifact that the pacemaker lead can sense. And it will, as you said, it will cause pacing pause. So a patient could have very long pauses while somebody is being receiving Bovie or electrocautery. Now, there are electrocautery tools that are less likely to do that. Some of you have seen Barry and I do pacemaker surgery using a so-called plasma blade, which is made by Medtronic, which is supposed to not cause as much artifact. There are also bipolar bovies, where instead of having a single stick that is used to cauterize the device, looks like a pair of forceps, and it cauterizes between them, and that's also safe. There's also something called a harmonic scalpel that uses ultrasound. It's very uncommon to find these in the present era, but all of those devices could theoretically be safe with a pacemaker. But why? So when you put a magnet on a pacemaker, what does it normally do? Does anybody know?
Makes it asynchronous. Like
Yeah,
change
it causes the pacemaker to pace asynchronous in an asynchronous manner. Unfortunately, every single pacemaker from every manufacturer is different. So you have to actually look up what is the response to a magnet on the pacemaker. In most cases, it will cause asynchronous pacing at a certain rate. It's different from defibrillators, by the way. We can talk about that another time. Magnets on defibrillators will often deactivate the defibrillator temporarily as long as the magnet is on it. It's an important safety feature for inappropriate shocks. But the bottom line is what surgeons are asking is whether you can make the pacemaker asynchronous so that they can use as much Bovie as they want without worrying that the heart rate is going to be affected. Generally, that's a safe approach, but the concern is that in the absence of sensing, when you're making it asynchronous, this type of thing that we're seeing here in this panel at 620 could happen, which is if the patient has a very low underlying rate and let's say the patient's in complete heart block with a rate of 27 and you put the magnet on and you're pacing at 60, the likelihood of a problem is low. However, if the patient happens to have a PVC during the pacing, and the device is pacing asynchronously, it is possible that a pacing spike could fall on a T wave and cause a very bad problem. I have not seen that happen, but there is absolutely no reason it couldn't happen. And so probably, what I normally will say is I'll ask them to try to use as little Bovie as possible and leave the pacemaker on. A lot of surgeons just won't do it. And I think it really depends on what they're doing. If it's a type of surgery where you need to Bovie for like 30 seconds in total for the whole case, I would argue it's much safer to just leave the pacemaker on. And what we'll often do is suggest putting the ground pad far from the surgical field and from the pacemaker pocket, and then to use the Bovie sparingly. Don't do 30 seconds of on Bovie. Do 5 or 10 seconds, give the patient a break, and then proceed again. So a lot of it really is going to, excuse me, is going to depend on what exactly you're doing and how bloody of an operation the patient is having. For example, if you're doing a heart transplant in somebody who's a single ventricle who has a pacemaker, that's going to be really, really bloody, and you really are not going to be able to tell the surgeon to not use electrocautery as much as they need to, because they're going to have to for life-threatening reasons. In that case, certainly asynchronous pacing makes good sense. The only other issue with electrocautery that I should mention is, in the past, pacemakers were not as well grounded, and very rarely there were case reports of people whose pacemaker was literally, the circuitry was fried with electrocautery and stopped working completely, causing asystole. I was not involved in this case, but when I was a fellow, there was this apocryphal story that was told about some patient who had a nasal polyp bovied in an ENT office and went into asystole in the doctor's office because this is now almost 30 years ago, but pacemakers were not as well protected against that today. That would be exceptionally rare to happen, but certainly the interference with the pacemaker is a real concern. So in this particular case that we're looking at on the screen, this would immediately warrant a visit to the cardiologist in order to assess the lead, both the sensing and the pacing. And sometimes we need to put the patient in different positions because it might be a positional issue. In other words, this patient could come in, lie down on the table, we do a test, everything looks perfect, but you still have to understand why this tracing occurred. And sometimes if you have a patient lie on their left side or their right side or stand up, bend over, you can sometimes reproduce these problems because sometimes it could be an insulation issue that only in certain positions is the problem, brought out. So this is a potentially very serious problem that requires I would say, a semi-urgent evaluation. Okay, any questions about that? All right, I think if that's the case, we'll stop at this point. I hope everyone has a great day. Thanks for joining.
Thank you.